so much. So normally, when I'm going to give a talk, I really carefully map out the narrative arc and make sure that I'm going to have a really convincing, strong argument at certain points and culminate to a strong finish and everything. And it was a little bit more last minute today, so it's going to be a little bit more casual. But I do think that we're going to have an interesting hour or so. I'm going to try and make a case for working together to address health equity in the region. I'll start off by talking a little bit about what health equity is, why it's really important, why we ought to do more to address inequities in health, and I'll finish off with some ideas for how we might move forward to work together to address inequity. I'm particularly honored to be here today and excited because part of my argument today is going to be that we're never going to be able to address inequities in health. These are really sticky problems until we have collaborative action. People from within government and outside of government, people in the private sector, people in communities, people in the health services sector, but also people outside of the health services sector. And today, with the LIN and with SHOP and with the diversity of all of you out there, it's a really promising sign that we're coming together to actually think about this problem. It's a great first step, so I'm really honored to be here. As I was putting together some slides last night, I came across this article in the Toronto Star. And, in a nutshell, it sort of highlights some comments from a former hospital president in Hamilton, suggesting that we do have problems with sustainability in the healthcare system, and I think those are very real. And he was sort of suggesting from his perspective as the former president of a hospital, how we might go about addressing these problems. And I'm not saying that his ideas are wrong. They're very sort of clear and present and concrete. The idea that we need to make some tough decisions, perhaps streamline some hospital services so that we can save more dollars. And I guess my point is that this is a typical short-term solution. A very concrete and achievable solution that will save money in the short term. And what I'm going to try and argue today is that while we might need to do that in some cases, we should also think about what we could be doing in the longer term to better address the social determinants of health, which I believe will strengthen prevention, reduce the burden of illness in general, and then alleviate some of the pressure on the healthcare system in that way. And the nice part of taking a preventive approach is that we'll also be able to achieve greater health equity. And as I'm going to highlight when I talk about why we ought to address inequities in health, I think you'll agree that that's going to make Ontario and your region a fairer place for everyone. A lot of what I'm going to talk about today is about thinking about what do we want the region to look like 10, 15 years from now. This is a blueprint I got about rapid transit that might be coming. I'm not even sure what the status of this is. I just sort of saw it as a vision from a few years ago, and I'm not sure what the idea is here, if it's actually going to go forward, but this is what I'm talking about, is what do we want the region to look like in concrete terms, not only in terms of the built environment, in terms of what transportation will look like, but in terms of the social environment, the services that we provide for members of our communities. And all of this comes back to the concept of the social determinants of health. It's the recognition that there's decades of research now that shows that a whole raft of things, not just the healthcare that we receive, determines how healthy we're going to be across our lifetimes. And there's a lot of evidence when it comes to health inequity that the social determinants are not equally distributed for everyone in our societies. There are some of us who have lived a life sort of nourished in terms of these social determinants, whereas there are other people who are lacking a lot of these in terms of adequacy. So this is a study from a couple of years ago, and I just wanted to give you, before we set off on this journey, a little concrete example of what I'm talking about by addressing the social determinants of health to strengthen prevention and improve health equity. This is research from, I think, a couple of years ago now, out of St. Michael's Hospital in Toronto, that highlights the very, very high prevalence of traumatic brain injury in the history of homeless individuals. It's a very provocative finding in terms of if you sort of sit with that for a while and think about the implications for why some people become homeless even. But what I really want us to focus on for today is this idea that the authors concluded with, the implications of learning that people who are homeless are living with a much higher burden of traumatic brain injury than the rest of us. If we really want to do something about improving conditions for the homeless, maybe even addressing that problem, we really need to think about how to develop supportive living environments for the homeless. So not just merely providing them with a home, but finding ways so that we can empower them to stay housed. And I thought this was particularly relevant because of SHOP's presence here today. SHOP is doing some of this in their own way through the services that they provide, and so they are strengthening the social determinants of health and improving health equity. And we need to think about, what are the opportunities for doing more of this for other populations that need these types of support. And so this is the concept of the social determinants of health. I'll come back to this a little bit later, but while we're looking at a concrete example, I just wanted to give you a little picture. It's this idea that if we look at the three racers there, the person at the top level there is achieving health in a relatively easy way, whereas the person in the middle row there has a few bumps along the road, particularly maybe in early life, and then sort of achieves a clearer path towards having a healthier life. Whereas some people in society end up with very sort of steep problems early in life, and those problems only get worse as they go across their life course. And so achieving health in equal terms is not something that we're currently realizing. And if we're going to do a better job of making sure that we can all live healthy, well lives, we need to do a better job of addressing those bumps in the road that some of us face. And you could think about those as the social determinants of health. So Bob Gardner was going to come and talk to you today from the Wellesley Institute, and Bob's a fantastic speaker, and one of the things he was going to do is to show you a video that I think is going to set the stage in a really nice way for what do we mean by thinking about how we can support the social determinants of health in our communities more strongly. So I thought we would maybe watch this video and then we'll continue on.
What is good health? And how do we move toward a healthier future? Many Canadians believe that a good healthcare system is the ticket to health. But good health is more than just doctors, drugs, and hospitals. Healthcare is what we access when we're already sick. Some of today's most prevalent healthcare issues include heart disease, diabetes, childhood obesity, and depression. But what are the causes of these issues? How often do we talk about what happens before the doctor? Let's look at the underlying differences between healthy and unhealthy societies. Starting with the facts. Although immigrants arrive healthier than people born in Canada, their health generally declines over time. People with low income are more likely to report poor health. Neighborhoods where good transit, healthy food, and public services are difficult to access are more likely to have higher diabetes rates. Why is this the case? How do we move toward a healthier future? To find out, we need to step outside of the healthcare system for a moment and take in the big picture. After all, healthcare is what we do when we're already sick. Let's look at the root of the problem, because changes at the roots benefit us all, no matter who we are. We're talking about things like where we work, play, eat, and live. We're talking about the social determinants of health. Access to healthcare is an important social determinant of health. But there are many others that are just as important, some that might surprise you. Working a secure job with benefits, feeling part of a strong and vibrant community, living in a safe, affordable home, living in a neighborhood that is easy to get around in with parks and community spaces, accessing healthy and affordable food, and having opportunities to pursue education. Our health and well-being is shaped by our daily lives and how our economic and social conditions affect us. These conditions don't work in isolation. In fact, they're all connected, like a big, complex web. Let's start making the connections. Access to education means gaining skills to find employment. A good job that pays well means you can afford to pay your rent and your bills. Having more affordable housing also frees up money for good and healthy food. Safe, well-connected streets in our neighborhood make it easier to get where we need to go and back home again. When all of this is available, we can better connect with our neighbors and communities. For parents, these also mean helping their kids do better in school. And let's not forget access to healthcare. We've only mentioned 7 determinants here, but there are many others. What about racism, sexism, and culture? What determinants play a role in your health? Because the social determinants of health are so closely connected, one change can trigger many others that affect your health. If every kid had access to healthy food and a safe home, imagine the difference it could make to their education and their health over time. The connections and the possibilities for good health are endless. So from small changes in your neighborhood, like clean, well-lit parks, to big steps in government policy, like a national housing plan, we can start making the connections to a healthier community, a healthier city, a healthier society, a healthier you.
Okay, so that, I hope at this point that we've got a handle on what this idea of the social determinants of health is. But let's talk a little bit more about inequity in health, because equity is a concept that implies some commitment. It implies that you believe that there are unfair differences in health out there that we ought to do something about. So, in general, I've done some research that looks at what the Ontario public thinks about health differences, whether the rich are healthier than the poor. Is that appropriate? Do we need to do something about it? In general, we find that if people believe that there are these inequities in health, these social differences in health, they think that we should be doing something about it in Ontario. I think the problem is with what do we do about it? How can we address these things? So I kind of want to start from the ground first with some definitions and a more core understanding of the concept of health inequity before we talk about the motivation to do something and then what we can do. When we talk about health inequities, we're talking about social differences in health. Countless studies out there in every country in the world will show that there are differences in health across levels of income. In many parts of the world, you'll see differences in health between racial ethnic groups, between men and women, across sexual orientation, in the workplace, by the hierarchy of the workplace, I should say, and depending on whether you're, say, born in Canada, come here as a newcomer or an immigrant, or whether you're coming here as a refugee, you've been displaced. There's a difference, though, in understanding differences, statistical differences in health between two population groups and an inequity in health. And I think that's an important distinction because if we crunch the data, we're going to see a lot of differences in health between population groups. And that's a statistical fact, say, that we find that a rate of one disease is higher in one group than in another. We would call those health inequalities, the presence of a difference between two or more people or groups on some measure of health, something we can capture empirically. And the question then is whether or not we expect those differences, and if we don't expect them, are they unfair? Do we think that they're unfair? For example, if you notice two population groups have a different health trajectory on some particular outcome, and it's articulated that there's a genetic cause for a higher rate of a disease in one population group, maybe a racial ethnic group compared to another, we might say that that's a difference. And yeah, maybe we should do something about it, but it's not necessarily an unfair difference. Health inequities are differences in health between two groups that we deem to be unfair or unjust. And they end up being these differences that we can identify systemic social causes. if we dig deep enough. And that implies that they're avoidable, or at least changeable once we recognize that they're there. So here's an example. In the US, there's actually a large literature articulating social differences in health. This study in 2008 found that African American patients were consistently less likely to be treated with the minimally invasive option for a range of common surgeries. So the concept, I'm sure a lot of you are familiar with minimally invasive surgery. It's, I had my gallbladder out about 6-7 years ago, and typically they would cut open your abdomen and pull out the gallbladder. Today they've got a more minimally invasive approach where I just had 3 little dime-sized cuts in my abdomen, and they used a series of tools and long scissors and snipped it out. And I was home the next morning, actually. Actually, I think I might have even been home that night. And recovery was a lot quicker, a lot less pain. And here's a study that shows that in the US, there's differences in who gets access to that kind of painless surgery. Now, what's critical is that at this point, it's just an inequality. Okay, we've recognized that there's a difference between 2 groups of people. It's in an outcome that I think is really kind of important: pain. Who's getting the more painless surgery? And what's critical then in deciding whether that's an inequality or an inequity is deciding whether that's an unfair or an avoidable difference and what's causing it. And so this is a way to think about that sort of calculus. We see a difference in quality of care in terms of access to minimally invasive surgery between, say, one racial ethnic group and another. And the idea is, what's the reason for that difference? There might be some understandable reasons for differences. There could be patient preferences that are cultural, where one population group simply wants to opt for maybe the more invasive surgery approach. I don't know why that would happen, but it's possible with other types of services. There might be clinical appropriateness or need in one population group or another that says that this is the approach we should be using for the best health outcome, and that irrespective of the pain dimension. But there could be a number of reasons why these differences are unfair or unjust. There could be racism on the part of healthcare providers, or institutional racism that sort of sorts patients into these types of surgery approaches. There could be clinicians who say that there are differences in appropriateness and need, but those could be colored by racism, for example. And there could be sort of long-standing, what we might call structural racism or discrimination, where the legal and regulatory climate of the healthcare systems broadly, not just in a given institution, are sorting patients into these different types of surgery options. And so the point here is that when you see a social difference in health, it's not automatically an inequity. You've got to sort of dig a little bit deeper, try and understand why it's happening. And when you discover that some of these differences are caused by things that we feel are unjust, then we ought to do something about those. This is one of the most famous examples of health inequity. It's from the Whitehall study in the UK. Sir Michael Marmot, who you might have heard about, was key in bringing these findings to light. He studied people in the government in the UK. He followed people up at this point for decades. And he showed clear differences in this case, coronary heart disease, depending on where you worked in the workplace. Were you somebody who is a CEO type, then your trajectory would be that lower line. Were you somebody who is sort of, maybe not quite the CEO, but some sort of an executive or a manager, you had a slightly worse, but still better than most people, trajectory for coronary heart disease. Clerical workers having a worse trajectory, and other workers, these might be people in janitorial services, having the worst trajectory for coronary heart disease. And it was a very elegant way to show that there are these social differences in health. And I think asking people to decide, is this fair? Maybe there are differences in how much people ought to make depending on their job. I think we could probably all agree on that. But should we be seeing stark differences in who's going to die from coronary heart disease? When they dug a little bit deeper, they were able to uncover, well, they've tried to uncover why are these things happening in the workplace. they sort of looked at some of the easy explanations. Well, there's differences in cholesterol, maybe because there's dietary differences. There's differences in smoking, maybe because people who are earning less money tend to come from environments where smoking is more common, and they pick up the habit. There might be differences in blood pressure, and those are all the colored portions of those lines at the bottom. And what was amazing is that that white portion at the top suggests that after accounting for those maybe common understandings of why there would be differences in coronary heart disease between these people in the workplace, the vast majority of those differences were unexplained. And when they dug a little bit deeper, they found that a lot of this could be explained by workplace differences in demand and control. Really, the idea that we all have high-stress jobs, but some of us have control over how we deal with those stressors, how we deal with those problems, when we can sort of put the work away for the night. Whereas other people are kind of always on. They're always being told what to do, when to do it, and how to do it, and don't have a lot of control. So to me, that's just a really great example of an unfair difference. Because of the jobs that we go out there, we get a job, and the conditions of those jobs, in terms of control and demand, we're seeing these stark differences in death from coronary heart disease. So it suggests that there are these problems in certain workplaces where there's, not enough social support for some people in certain jobs, a low effort-reward balance, poor job security that are driving these stress-related differences in health. Here's another example of a really stark social difference in health. In the US, still to this day, African American infants are more than twice as likely to die within the first year of life than white infants. And if you think that's shocking, we see similar trends here in Canada. I'm studying data from Nova Scotia. This isn't a racial ethnic difference, this is an income difference. And infants born in the lowest 10 percentile of income, so the families with the lowest levels of income, are more than 3 times as likely to die in the post-neonatal period, basically the first year of life, than those born to the wealthiest families. So this is a really stark difference in what happens in the first year of life. And I think this is important when we're talking about health equity, because sometimes we see differences in health at the level of adults. And, we might decide, is this unfair, unjust? And some people will say, well, smoking and dietary differences, people have a responsibility to live, to make healthy choices. But here we're seeing that this is something that starts when we're babies. Do we really expect babies to be able to do something to improve their health in that first year of life? Obviously not. And then is it right to blame families for what's happening to their babies? So we need to do a better job in society, even today, of creating a more equal playing field for health and well-being. So when we think about these social differences in health, I'm not sure if I can go back, but not all that important. Oh yeah, there we go. We're going to see a lot of differences in health and well-being between social groups, and the real question is, why are there these differences? And I think in a lot of cases, we're going to come back and recognize that there are social determinants of health that are imbalanced across our society, that we can do a better job of making more equal. Now, why study health inequities? I'm sure that because you're in this room today and you're interested in doing something about health inequity, maybe I don't even need to convince you why we need to study inequities in health and do something about them. But I think it's important to think about the arguments, because we're going to be interacting with people, partners in our own workplaces, in our own sort of domains when we leave here today, and we're going to have to do some convincing. We're going to have to find new partners to work with to try and strengthen the social determinants of health. And so I think it's important to think about the rationale. On the one hand, it expands our understanding of what determines human health and well-being. So the better we understand the social determinants of health and how they affect us and lead to these inequities, hey, that's us getting smarter as a society. It's going to help us create smarter healthcare systems, smarter community services, fair policies in government. We've done some of this sort of grand problem solving as societies before. This is mortality rates in the US over the last century or so, showing that mortality from infectious diseases used to be the largest killer, basically. And we found ways to deal with that, largely through the sanitation revolution, making sure that people had clean drinking water, sewage systems, vaccinations. And we've managed to drive infectious disease mortality in North America and many parts of the world down to a negligible amount. Today, we're dealing with chronic diseases. So this is the same sort of 100-year period or so, showing that the share of mortality from infectious disease has dropped. The share of mortality attributable to accidents has sort of stayed the same. Accidents happen, it's hard to avoid those. But what's really exploded over time is death from chronic disease. And so we need to do a better job of finding how can we prevent chronic diseases. This is what's really costing our healthcare systems a lot of money. And as the population ages over the next 20 years, this is what's going to really make our healthcare systems unsustainable. Well, if we look at all of the major chronic diseases, you're always going to see social differences in those health outcomes. This is data from Ontario, from the Power study, that shows that across all of the major chronic diseases, the wealthier you are, the healthier you are. So if we're going to do something about this problem of chronic disease, we might do best to focus on those of us who are less wealthy and those of us who are marginalized in other ways, because those are the people in our societies who are suffering the most. And if we want to, therefore, reduce that burden, make our healthcare systems more sustainable, that's where we should be focusing our attention. I think there's also a moral imperative to understand and eliminate inequalities in health that we think are unjust and avoidable. We've demonstrated our commitment to these types of ideals in many ways. This is Article 25 of the UN Declaration of Human Rights, which says that everyone has the right to a standard of living adequate for health and well-being, including food, clothing, housing, medical care, and necessary social services, including the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other problems of livelihood. Furthermore, that motherhood and childhood are entitled to special attention, essentially. This is really a manifesto for a social welfare system, and I'm not knocking Ontario's social welfare system. We offer a lot to our residents, but do we really do a great job of ensuring all of these things: food, housing, social services? I think we could probably do better, and this is something that we've committed to as a country. Article 12 of the International Covenant on Economic, Social, and Cultural Rights: everyone ought to have the enjoyment of the highest attainable standard of physical and mental health. And this requires governments to take specific steps to reduce infant mortality, improve child health, et cetera, et cetera. And the point here is that we all have a right to thrive, and governments have a role to play in that. In Canada, we have recognized, I think, this moral imperative, and we have done things about it. We're world famous for our Medicare system, which does not discriminate regardless of class, wealth. We all have access to the same healthcare system. It's going to be publicly administered. It's going to be accessible wherever you are in the country. It's going to be comprehensive. Sure, there's challenges in meeting some of these pillars as societies evolve over time, but there's always going to be those sorts of challenges, and I think it's a pretty amazing achievement in our country. But our health leaders continue to say that we have to do more than just Medicare. So this is the Chief Public Health Officer in Ontario, not just in her 2008 report, but ever since then, and even before then in some ways, has called for more action on inequalities in health, really nicely laying out that health inequalities are fundamentally societal inequalities. These are social inequalities that are manifesting in health differences, and that we need to work together, individual but also collective action. There needs to be policy changes, not just targeting individual choices and behaviors, but to consider the social and environmental conditions that shape these choices. I think this is a really amazing statement from one of our leaders here in Ontario, and I think it sets a really, really challenging path forward. How are we going to do this? And this has been recognized before, that achieving health equity It's a very hard nut to crack, and you're not going to do it just by politicians coming up with solutions. It's not going to happen just through communities getting angry and wanting something to happen and trying to do something on their own. There needs to be collaboration. There needs to be collective action within our societies to tackle some of these challenges. So if we're going to tackle inequities in health, we need to better understand what causes them. I think we've spent a lot of time, and I think it's sort of been fostered through our, let me put it this way, we've done great things with Medicare. Installing that in Canada, it reflects a commitment to the moral imperative to do something about inequities in health. But it also highlights our focus on a biomedical perspective on health and what shapes our health and well-being. And I think that's reflected when we think, if you go to your doctor, and, not to disparage doctors, my father's a doctor, but if you ask them, what causes health? What can I do to make sure that I'm going to be healthy? The traditional determinants of health that we talk about in the media are biomedical. Well, there's genetics you got to worry about. You need to make sure you've got access to good health care. There is a role for some things in the environment like pollution, water quality, and your lifestyle choices and your health behaviors are really critical as well. So let's focus in on one of these traditional determinants, lifestyles and behaviors. And let's think about this concept again that we might have different challenges in achieving a healthy, well life, including achieving some of these lifestyle and behavioral choices. So if we think about what the determinants of health are today, going back to the Lalonde Report of 1974, and ever since then, over the last 30, 40 years, a number of people have proposed expanded versions of what those determinants of health are. And health services are merely a fraction of what we recognize now through evidence shapes our health and well-being. Regardless of whose conception of the determinants of health you agree with, there's widespread agreement that there are so many other things out there that we need to think about if we really want to do a great job of ensuring healthy and well conditions for everyone in our societies. These social determinants of health work by maybe affecting our health in more proximate ways, but also by affecting our health through our social experience. By who gets access to good quality housing, at what cost, who's interacting with the police more so than other people, and in what type, and sort of in what mode, for what reasons, who's getting opportunities for advancement in their careers and wealth attainment. We could go through this whole list, but it's just to highlight that the social determinants don't just give us access to things that directly impact our health. Sometimes they affect our health and well-being in more distal ways that we're only going to uncover through careful analysis. And that's why some people have thought about the social determinants as the causes of the causes. So you think about the traditional determinants of health. Well, what causes those? Let's look at a concrete example of a health inequity in Canada or in Ontario related to our lifestyle and behavioral choices. So here's one of these problems, these health problems that's going to make our healthcare system unsustainable in the next 20 years, diabetes. Diabetes rates are exploding in the province. What do we know that determines diabetes rates and obesity, by the way? We recognize now that our risk for diabetes and obesity is determined by our energy balance. How much energy are we taking in, and what kind of quality is it, our diet, and how much energy are we using up, our physical activity. And here's the expected social difference in diabetes rates across levels of income, largely for men and women. The wealthier you are, the less likely you are to have diabetes. Well, let's think about those determinants of diabetes. If we think about diet, there's also a stark difference in food security by income in Ontario. Those who are of lower household income, 1 in 4 of them report not being able to meet their food needs in a given week for their family. Whereas in the highest income groups, that's less than 1%. And there's a gradient. So can we really expect people who are less wealthy to make those responsible dietary choices to prevent diabetes, help make our healthcare system sustainable, if they don't actually have the capacity to provide healthy meals to their families on a given week? We can think about physical activity. This is a map of Toronto, and the darker parts of this map are less activity friendly, meaning that the infrastructure, the built environment of these neighborhoods don't have as much opportunity for safe bicycling, for walking even. Maybe the sidewalks aren't as great. There's not as much public transit access. And so this is what's called an activity friendliness index. Maybe you live in the Toronto area and you can sort of figure out where you live and see what sort of environment you live. Well, researchers have studied diabetes rates across these neighborhoods and shown that the more activity friendly your neighborhood is, the more likely you are to be physically active and the lower your diabetes rates are. So again, if we expect people to be physically active, take on that responsibility to, help our societies be healthier, have sustainable healthcare systems, cherish our Medicare system, is it fair to expect everyone to be able to be as physically active if we're not providing adequate infrastructure to everyone? And so this is the concept of intersectoral action for health. When we think about things like food security, when we think about who's responsible for developing infrastructure, we can look at the ministries in Ontario and we can just quickly already underline a whole range of ministries that impact activity friendliness in neighborhoods, that impact food security. And this is, we're going to talk about solutions today, and I know that a lot of you are in the health services domain. I'm going to talk to you about a broader approach that I think is really important at this point, which is intersectoral action for health, that we need to start finding partners outside of the health services sectors who we recognize have a role to play in making sure that, the burden on our own clinics, say, or the burden of the services that we're providing, the social services, are going to be sustainable in the future. So who can we engage to help make our jobs easier, in other words? Let's just pick on one particular ministry for a short period of time. I apologize if somebody's from Community and Social Services here. For example, what policy levers are there at the Ministry of Community and Social Services? Well, the ministry does offer a special diet supplement to people who are on ODSP and people who are on Ontario Works or welfare. But guess what? That special diet supplement, and let me just sort of articulate what that is, $250 extra a month to help you meet your food security needs. However, at present, you have to have a doctor agreeing that you meet one of 29 specific physical health ailments. And then they sort of write you a prescription that the government will then say, okay, you deserve this food supplement. So this is the model itself I think is great. I think it's great that we recognize that some people need a little bit more in order to meet their food security needs. But I think the data that I've shown you before suggests that the problem is more widespread. And I think that maybe we could do a better job at preventing diabetes and obesity if we make this special diet supplement a little bit more accessible. Not just if you've gone to see a doctor and have sort of gone through some examinations and you meet one of 29 conditions, and they've been narrowing those conditions over time, by the way, because this is a program that's being accessed a lot, right? It's actually a great thing. It's something that people really need, but it's not sustainable at present because the government's worried that they're going to be spending too much on it. And I think we need to convince people that this is actually a good way to spend our dollars that's going to actually reduce the burden on our healthcare system in other ways. So if we look at this problem a little bit more, we can see that people on Ontario Works and ODSP have really, really high rates of food insecurity compared to the rest of us. 6 out of 10 are food insecure. So it's not just going to be, a small cross-section of those people on Ontario Works and ODSP that have a specific health condition that need or deserve this food supplement in their monthly income, 6 out of 10 on Ontario Works ODSP need more food security. So can we expand the special diet allowance to support anyone living in poverty? When we think about who's more likely to live in poverty, this includes people from all over our society. So I think there would be a lot of political support for this kind of movement as well, because it's not something that's so targeted to sort of benefit one group or another. So just to sort of reflect a little bit, I think to tackle the growing health and economic burden, inequities, and associated diseases of diabetes by supporting measures to ensure that all Ontarians have income, food security, neighborhood activity friendliness. These are just some quick ways that we can think about engaging more people from the government to tackle the problem of health inequity. So this idea then that intersectoral action is key for health equity. It's not new. It's been something that's been argued for maybe even before, but most prominently in the 80s when the Ottawa Charter was signed, which was really a landmark health promotion document. And even back then, they called for a variety of actors from across government sectors, outside of government, to address the social determinants of health, those ones that are unresolvable by individuals, using their responsibility, using their behaviors to deal with them on their own. There's all sorts of examples around the world of how to use intersectoral action to address health equity. In some cases, it's used to address a specific determinant of health, like physical activity or food security. People will come together to strengthen that particular determinant. Sometimes it's used to address a specific disease. We need to do something about diabetes. What can we do? Who should we bring into this? Sometimes it's been used to help support specific populations that we recognize are suffering from inequities, figuring out what their needs are and who should we be bringing in under the tent to work on this problem. It could be used to, say, address geographic communities, maybe rural communities that are suffering from a lack of social determinants, or by trying to address some of these behaviors that we typically decide are the responsibility of individuals. One concrete way to do this intersectoral action is the idea of health impact assessment. Health impact assessment, so the idea of intersectoral action for health might seem scary to some people. How are we going to start to convince people from other ministries who have their own problems, their own bottom line to worry about, their own mandates to work on our health problems? Health impact assessment is a tool that's been developed that makes that problem a little bit easier. It's essentially a decision support tool for policymakers that can be applied systematically. Wherever a new policy is being made, you might say, fill out this health impact assessment before you finalize that policy. And it really just asks policymakers to think about what are the possible impacts to human health? Are those impacts going to be equally distributed across the population? What could we do to change your policy as implemented so that it still meets your goals but avoids some of those health impacts? So it's really just a thought exercise to help decision support. And it's been implemented in many places around the world at this point. A very local example, Peel Region. They have passed a law in their sort of planning departments that says that anytime a new development is going to happen in our region, we need a health impact assessment to be completed. We need you to consider what you're going to be changing about Peel Region. What are the possible health impacts? And how can we let you go ahead with this project as you wanted to, but avoid some of those problems? I think it's a really fantastic example. And it had maybe some bumps in the road initially, but they've sort of gotten it up and running, and it seems to be working quite well, including through the private sector partners who are subject to these health impact assessments. I've heard sort of anecdotal evidence from the team at Peel saying that initially there was a lot of hesitation that, this is another regulation. Why are you making us do this? We're trying to sort of, strengthen your economy by bringing new condos in. But after some time, the problem that was sort of at the center of their fear was, we really just want there to be an equal playing field, that everyone who's going to apply to do something in this region is subject to this, that this is something we all are going to agree to buy into. And that's something that you can do by making it sort of systematic and putting it into policy and saying that this is something that will always happen now. In the province more broadly, we actually have a similar tool that can be applied not just to planning decisions, but more broadly to any decisions in any sectors. It's called Health Equity Impact Assessment. And the difference between health impact assessment and equity impact assessment is really just that there's more of a focus on the impacts on inequity with the HEIA tool. This is a tool that's been developed by the Ministry of Health in Ontario, and currently it's been applied largely within the health services sector, so to help public health units, CHCs, LHINs think about how they can facilitate more equity in the services that are provided. But through examples in other parts of the world, in Peel region, the province of Quebec uses HEIA on all of their policies across ministries. I think we could apply this tool outside of the health services sector. So if you, as somebody, an actor in the health service sector, recognize that there's a real issue here that is only going to be solved if we engage people from outside of the health services sector, you might want to encourage the use of HEIA to help surface some of the problems that need to be addressed. And so, one way that we might do this to address diabetes is to, assess the positive and negative health impacts of the current regime of social assistance by the Ministry of Community and Social Services by using this impact assessment tool and thinking about, how is the rate that's given to people determined? Maybe looking at the Ministry of Health Promotion when they existed, they came up with the cost of a healthy food basket, a nutritious food basket. So we've sort of parameterized how much does it cost people to eat healthy. Maybe we should be integrating that into the amount that's given to people on Ontario Works to make sure that they not only have enough for housing and that nutritious food basket, but then for other costs of living. And I think an HEIA sort of activity could help surface some of those solutions. So it's something that is, you might be hearing about it more later today. I hope you are. It sort of starts with the needs assessment, the identification of priority populations, problems, objectives that are relevant to the organization, and that might sort of surface specific health inequities, identify some of the less healthy communities within your region. It does involve some process of research, analysis, perhaps consultation, because how can we expect condo developers or people from the Ministry of Community and Social Services to be health experts and to be able to naturally identify, what are the possible health impacts of this policy. So there is a bit of collaboration involved in identifying some of those problems. Recommendations, what can we do then based on our analysis to make sure that the needs are going to be met, that those priority populations are going to be supported through this policy change. Implementation of the revised policy, and then the recognition that, maybe we won't get it right the first time, and this is an iterative process, and it's ongoing. And at some point, we should revisit this HEIA, maybe when this policy has been implemented for a few years, and let's see how it's going. And it sort of works in a cycle that way. What's critical is that you can sort of use this tool prospectively if you sort of want to get people while they're developing new policies, and you anticipate that this might be a problem for us, or it might be a problem for a certain population. You would want this tool to be used at the beginning of that cycle. On the other hand, if you sort of recognize that there's already a problem, there's a policy that's just not working, it's making inequity worse, you can also apply this tool retrospectively to sort of review and reassess a policy and then encourage a new cycle of policy change on that issue. So I think I'm closing up here. And I just wanted to sort of bring us back to this problem that I came across last night, which is, okay, we've got to make tough, controversial decisions because we can't afford our cherished healthcare system in Ontario. And if we can't afford it now, we're not going to be able to afford it in 20 years when the population ages. And so, sure, there are ways that we can address this problem quickly, but it's going to mean breaking down our cherished healthcare system. And maybe currently that's going to be feasible, but again, I'll bet you that in 20 years we're rebuilding a lot of this infrastructure to meet the demands of our aging population. And so how can we think alongside some of these more short-term solutions about longer-term solutions that fundamentally change the social determinants of health in Ontario? Thank you.